discuss yesterday's paper, that is the INICET May 2022 Obs and Gynae, the questions from Obs and Gynae. And I am Dr. Reena Chawla. I have my own classes. You can follow me on YouTube. You can find me on YouTube. You can subscribe to my channel. I also take classes for Docami, and you can subscribe to them also if you want to hear more of my lectures. So now, without wasting further time, let us just, before we start the discussion, a quick analysis of the exam. So the exam, when it comes to talking about OBG, let me just get my pen in order. Yeah. So lots and lots of OBG questions. Okay. What I counted was indirect and direct. So there's some subjects which overlap, like forensic and medicine and pathology. But all in all, there were more than 30 questions, which is a huge number from OBS and Gynae. And to be honest, this is my personal opinion. I felt it was a difficult paper. Most of the questions, the level of difficulty was quite high. There were many factual questions, so very less clinical based questions, very less images, so very unexpected from the current trend what you've been seeing for the past few years. Lots of clinical, lots of images. This was a complete change. So there were lots and lots of factual questions. If you know the answer, you know it. If you don't know the answer, you don't know it. And it was definitely a difficult paper. There were many questions which I had to refer to and find the correct answers to, and very rare topics which you never see in daily life, like leprosy in pregnancy, which is even finding the answers to this was a task, because most books would not even talk about such rare things. Okay, then things which have never been asked before, like lupus nephritis. Again, not many images, clinical scenarios. Some multiple correct options where they match the following, put in order, which is typical of INICET. These were there. Okay, and very few recalls. I think only 2 to 3 of the entire OBG questions were recalls. Very few from the expected, commonly asked topics. But all in all, it wasn't a very. I think most of you have this feeling. It wasn't a very. It was a very unusual paper. But always expect the unexpected. You never know what's going to come. But what I think for NEET PG is the upcoming NEET PG would stick to the usual pattern. That is my opinion. INICET, because it's a relatively new exam, because there are many different institutes involved in setting the paper, that's why it was sort of a googly. But NEET PG usually sticks to the regular pattern and wouldn't be a surprise. So don't change your study methodology based on this paper. Continue doing what you were doing. That's very important. Concentrate on previous year recalls, the last 2 weeks, last stretch. Previous year recalls are very important. Don't go by what came in yesterday's paper. So let's start with the discussion. The first question: all these investigations are cost-effective screening tests done routinely in pregnancy, except, and this is an easy question. Okay, so bacteriuria is done routinely, VDRL is done routinely. This is not done routinely, and screening for GTM is done routinely. I don't think I need to explain this. We all know routine antenatal care investigation, so I'm not going to go into very much details, especially for the simple, straightforward stuff. If you have any doubts, you can write them in the comment section, and we will get back to them later. Okay, now next question. Again, this was a difficult one. The cerclage procedure not done during pregnancy is it lash? Is it laparoscopic cerclage? Is it worms, or is it Benson's procedure? So, um, so this question, the correct answer is the lash procedure. Now remember, lash is the only procedure. It is the only procedure which is done prior to pregnancy, not done during pregnancy. So when we talk about cerclage procedures, we have transvaginal and we have transabdominal. Okay, transvaginal procedures can be done during pregnancy, and most of them are done during pregnancy, and the lash procedure is done prior to pregnancy. Okay, so this is basically when there's a defect in the anterior cervix. So what we do is we remove that wedge sort of shaped defect in the anterior cervix, and we suture it up. And this is done prior to pregnancy, and it's a very rarely done procedure, only if a defect is actually recognized. During pregnancy, we know the most common procedure as the McDonald stitch, and then the Shirodka stitch, and worms is also done during pregnancy transvaginally. This is the most common. Shirodka is slightly higher and anatomically a little more correct. Now, transabdominal, we have the laparotomy procedures. Benson and Duffy first described this several decades earlier, and now we have the laparoscopic procedure. Now, remember, transabdominal procedures, especially the laparoscopic one, can be done prior to pregnancy also, but it can be done during pregnancy also. So, in this question, you can actually have both the answers, but the more correct is lash, because lash is the only procedure which is done not done during pregnancy. It is done before the woman plans to conceive. Laparoscopic cerclages can even be done before pregnancy or during pregnancy. For both lash and laparoscopic or transabdominal procedures, delivery is always by cesarean section, and you can leave the stitch in situ so that she can have her second or third or whatever number of pregnancies she wants to have, and then once she's done with completing her family, then you remove the stitch. So that's the advantage of a transabdominal cerclage. So I hope that's clear. Okay, next question, which is incorrect regarding magnesium sulfate in preeclampsia, eclampsia. Also, remember there were a lot of questions with a lot of matter content in them. I've tried to be as accurate as possible. A few of them I may have got them wrong or incorrect. Or if you want to correct me, please feel free to do so. These are all recalls, so we can never be 100% sure, right? Okay, so it has an anticonvulsant effect on the cerebral cortex and simultaneously lowers the BP. Maintenance dose is given for 24 hours after delivery, or in the event of postpartum seizures is given for 24 hours after the last seizure. Maxulf quietens uterine activity, and this action is dose dependent. And Maxulf is entirely excreted by the kidneys, hence the initial loading dose can be given irrespective of renal function, but maintenance doses have to be titrated as per the GFR. So which is wrong? Okay, so the first is the wrong answer. Okay, and you believe me, to be honest, when I opened Williams today to recheck the answers, these have been picked word to word from Williams. In fact, many of the questions on pyelonephritis, the question on GDM, the question on lupus nephritis, word to word, and these sentences have actually been written in italics in Williams. Tables have been picked up directly from Williams. Okay, now Williams, you know, as an undergraduate, it's not expected to be a standard reading book, but I think those who are now going to prepare for INICET, those who really want to crack the INICET, you should start picking up your Williams. And the 26th edition is now out. It got released a week back, so that's new information for you all. So those who are just starting to study to prepare for the next INICET or next year INICET, my suggestion is start reading Williams. Like your Harrison, start reading Williams, because these were picked up line word to word from there. Okay. Now, what does Williams say? Williams says magnesium most likely exerts a specific anticonvulsant action on the cerebral cortex, but it is not given to treat hypertension. Now, many other places, and I agree with this, many other books say it does cause some amount of it does lower the BP slightly, but Williams clearly says it is not given to treat hypertension, and that's why this is the wrong answer. I mean, the correct answer, the wrong statement. Maintenance Maxup therapy has traditionally been continued for 24 hours after delivery. For example, eclampsia that develops postpartum, you continue it 24 hours after the onset of convulsions. Then also remember that magnesium sulfate is entirely excreted by the kidneys, but remember the loading dose is still given the same dose. We don't load the loading dose even if she's in renal failure or acute kidney injury. If it's there, we still give the same loading dose, because that is what will help us achieve the therapeutic level which is required to stop her seizures. After that, the maintenance dose needs to be altered with the diminished GFR. So remember this loading dose, even if she's in renal failure, you still have to give that much loading dose, because that therapeutic level has to be achieved. And remember, magnesium sulfate does cause uterine quiescence, hence it is used as a tocolytic, but this is dose dependent, okay, and only when the serum levels are this high that uterine quiescence will happen. Okay, so it is dose dependent, right? So this is why this was the correct answer. And this is again word to word from Williams. Okay, next question, which is not included in the diagnosis of preterm labor. And I think we all know this. Okay, so preterm labor is diagnosed when there are uterine contractions with cervical changes, and the cervical changes are the cervix should be more than 1 centimeter, or the cervical effacement should be more, and the cervical effacement should be more than 80%. Okay, and some guidelines, especially the American guidelines, do specify 4 contractions in 20 minutes or 8 contractions in 60 minutes. Cervix is all cervix. The position of the cervix does not matter. What matters is the dilatation and the effacement. Okay, next question, which is incorrect regarding the pathogenesis of preeclampsia. Again, long statement like questions, but it was not that difficult, this question. So angiogenic factors play an important role, and in preeclamptic women, there's an increase in what is this soluble FMS like tyrosine kinase 1 and a decrease in placental growth factor. Vasoconstriction leads to ischemia, necrosis, hemorrhage, and end organ damage in preeclampsia. Prostaglandins play an important role. There's decrease in thromboxane and increase in prostacyclin thromboxane ratio in preeclampsia. And endothelial cell dysfunction leads to reduced nitric oxide levels, and this causes a clinical presentation of preeclampsia. So the correct answer is this. So we know that angiogenic factors play a role. And so what are the two things which are increased? Remember, SFLT1 and soluble endoglin. Okay, these two are increased and are also used as predictors of preeclampsia. What is decreased? The growth factors, placental growth factor, vascular endothelial growth factor, and also PAP-A. These are decreased in women who develop preeclampsia or women who have developed preeclampsia. Remember, the S1s are increased and the growth factors and P1s, PAP-A, are decreased. So this is important. What you need to know, also we know vasoconstriction, vasospasm happens, but prostaglandins do play an important role, but this is opposite. So there's an increase in thromboxane A2 and there's a decrease in the prostacyclin thromboxane ratio. So that's why this is the wrong answer. Quick diagram about uh, um, um, pathogenesis of preeclampsia, and I'm sorry, I was so this is correct, right? So there is the increased SFLT1, increased SVEGF, so all the S1s are increased, the growth factors are decreased, okay, and the thromboxane is increased, prostacyclin is decreased. So remember these, and I won't go into too much detail of pathogenesis of preeclampsia. It's a very long topic, but very, very important. So 2 questions here on hypertension and pregnancy. Very, very important topic. So it is a high yield topic, but the questions that came from them were a little different. Okay, next question. Again, a difficult question. A woman who has been taken tamoxifen following breast cancer treatment for 5 years now wants to conceive. How many days after stopping tamoxifen can she conceive? And the correct answer is 3 months. And this is given in Williams again. It is also given in RCOG, and this is where I actually studied this from. Okay, so what actually tamoxifen is a teratogenic drug, right? And it has a very, very long T half. A T half is around 2 months, right? So what is recommended, and what Williams says is reasonable to delay conception for 2 to 3 years after breast cancer. Okay, after breast cancer treatment, because recurrence is common. So reason to delay conception altogether in a woman who has had breast cancer. Hormonal contraceptives are contraindicated. So this is just some things about pregnancy following breast cancer. Copper containing intrauterine devices are the contraceptive of choice. Women on tamoxifen, now this is where the question was asked from, extremely long T half, and it is teratogenic. Delaying conception for at least 2 months is what Williams says, and 2 to 3 months is what RCOG says, right? So the correct answer is, of course, 3 months here. Okay, and that's because of the long T half. Okay, women who have received adjuvant chemotherapy with, and this is another important point since we're discussing this, since it's never come before. What you need to know about pregnancy following breast cancer is women who have received chemotherapy with anthracyclines can cause cumulative dose-dependent left ventricular dysfunction, rarely cardiomyopathy. So when these women who've received anthracyclines become pregnant, always get an echocardiography done because of the risk of cardiomyopathy. So this is another important point. So 2 important points in breast cancer. In fact, 3 contraceptive of choice is copper containing intrauterine devices. Okay, and second is tamoxifen should be stopped 3 months before planning to conceive. And those who received anthracyclines when they become pregnant should have a echocardiography done. Next question. A 37-year-old woman who is unmarried is on OC pills. She's sexually active. She visits a gynecologist for routine screening. Her mother has breast cancer at 55 years. Her sister had ovarian cancer at 40 years. What will you advise? And this I think was relatively simple. The answer is genetic testing and BRCA testing. Now, remember BRCA1 and BRCA2. BRCA1 has a 40% risk of ovarian cancer. BRCA2 has a 20% risk. Very, very important. Both have around a 60 to 70% risk of breast cancer. Okay, so in women with two first degree relatives, the risk of a female first degree relative having an affected gene could be as high as 35 to 40%. So, this woman in question has a very, very high risk. So, we will advise her genetic counseling. And if the risk is substantial, in her case it is, we will offer her BRCA 1 and 2 testing. What are the other important points? If she suppose she's BRCA positive, and she wants to conserve fertility, she's still not pregnant, wants to think of pregnancy, advise her a transvaginal scan every 6 months and start mammography for her. OC pills are recommended in high risk women. Okay, this reduces the incidence of ovarian cancer. So, ovarian cancer, to reduce the incidence, let her continue the OC pills, get a TVS done. And those who do not wish to preserve fertility, if she says, I'm done with my family, I don't want to have kids, get her a prophylactic bilateral salpingo oophorectomy done after the age of 35 years. And annual screening breast cancer using mammography and ultrasound and MRI, a combination of these three, start this at the age of 30 years itself. Next question, which is incorrect regarding acute pyelonephritis in pregnancy, and this one had me stumped. Okay, because it everything from to me everything seemed correct, but when I went back to the book and I read, so what are the choices? Oral antibiotics once afebrile, hospitalized, and urine blood cultures, maintain urine output more than 50 ml. IV crystalloids can be given. Discharge if afebrile for 72 hours and continue antimicrobials for 5 days. What is the wrong statement? The wrong statement is the last one. Okay, and why is it wrong? Let's go to Williams. This table is from Williams. Okay, what does Williams say? How do you manage acute pyelonephritis? It says inpatient management, obtain urine and blood cultures, do these investigations, monitor vital signs frequently, including urine output. And they say this is the cornerstone of management. It's written in italics. This is the cornerstone, is establish a urine output more than 50 ml per hour. So this is definitely correct. Administer IV antimicrobial therapy, obtain a chest x-ray if there's dyspnea or tachypnea, repeat hematology chemistry in 48 hours, change to oral antimicrobials when afebrile. This is also correct. But see here, discharge when afebrile 24 hours, consider antimicrobial therapy for 7 to 10 days, not 5 days. It is 7 to 10 days. So these small things can leave you confused. All right. And this left me also confused until I went and checked the book. So, um, this is why I'm saying those who are very interested in INICET, you should, like you read your Harrison, you should start now reading Williams, is my suggestion, because everything, most of the things were given, I think, except leprosy in pregnancy, everything else has come directly from Williams and word to word. So you can see the actually word to word statements have been just picked out from this table. Okay, next question. Again, a question which had me stumped. As per WHO SAGE guidelines, the recommended dosage of HPV vaccine in 9 to 14-year-old girls is, and I just recently came out with a reel on Insta about HPV vaccination in pregnancy. I came out with a reel about a month back. Okay, and where I had said 9 to 14 years old girls, you give 2 doses, and above 15, you give 3 doses. This is what WHO recommends. But the WHO stumped us all by coming out with new guidelines in April 2022, which is just like a month ago. Okay, and what did they say? They said the correct answer is 1 or 2. So, what the WHO, what is SAG? SAG is basically the strategic advisory group of experts in the WHO. What they've been saying is that the 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 rate of HPV vaccine is very, very low in many countries. And one reason they have determined is that girls don't come for the second or the third dose. Those less than 14 don't come for the second dose. Some people don't come for the second or third dose above 15. So what they said is even one dose is enough. Okay, so if she's less than 14, what they've said is even a single dose or 2 doses, so 1 or 2. So in April 2022, the WHO SAGE group said that a single dose of HPV is comparable to 2 or 3 doses in delivering protection against HPV for type 16 and 18 at cost 70%. Okay, and from women aged 9 to 20 years, countries may choose a 1 or 2 dose schedule, and for women more than 21 years, a 2 dose schedule is now recommended. So, what was 2 doses before 14 has now become 1 or 2, and what was 3 doses above 15 years has now become 2. Okay, so they have basically said you can omit 1 dose is basically what the current WHO recommendations as recent as April 2022 is what they've said. Okay, so please understand this. This is the newest guideline, and that makes me rethink that yes, the paper is prepared as recent as a month before the exam. It's not prepared many months in advance, so you should be up to date with the latest important guidelines. And HPV vaccine is a high yield topic, so those high yield topics which recent updates have come out, we need to be updated with those. Okay, next question on HPV. This was an easy one. Which of the following is caused by HPV high risk types? And this is the answer. Laryngeal papillomatosis is caused by low risk HPV types. Okay, next question. Another easy question. So, vas deferens and seminal vesicles are absent, and we know this is a cystic fibrosis. Okay, so cystic fibrosis, there is mutation of the CFTR gene. Mostly there is congenital absence of the vas, but also of the seminal vesicles. That is rarer, but that can also be seen. What is Kalman's? Kalman's causes hypogonadotrophic hypogonadism, and there is primary amenorrhea and anosmia. Very important. This question has come in the last INICET. It had come as primary amenorrhea, and again it's come now as anosmia. So this is a high yield topic. Klinefelter syndrome, we all know this, and Y chromosome microdeletion causes male infertility. That's why it's important to know. And this is the second question, which the following is used with Kalman's, and the answer is anosmia, not precocious. Primary amenorrhea is associated, not syndactyly. White forelock is seen in Warrenberg's syndrome. For those who are interested, Warrenberg syndrome is associated with the white forelock. Okay, consider the following and place them in correct order in the seminiferous tubules. So this is also an easy question. The correct order would be myofibroblasts, which are basically precursor um, uh, stem cells, and then spermatogonia, primary spermatocytes, spermatozoa, and spermatid. And this is how it happens. I will not go into the details, but this is the correct order. Easy question. Next question. A 37-year-old man and a 33-year-old woman have two children. They have been trying to conceive since a year but are unsuccessful despite regular intercourse. On evaluation, the man is found to have hypogonadotrophic hypogonadism. Which of the following will be associated with this? Okay, so basically in hypogonadotrophic hypogonadism, they are asking what will you find, and what is the correct answer. This is again is sort of a higher topic. Previous years it has come. Okay, so this is what will be found. So they just made it into a clinical based questions. Low FSH and LH, low testosterone and oligospermia seen, high prolactin is seen. Okay, and both FSH and LH are low. So it's hypogonadotrophic hypogonadism. This was a multiple answer type of question. Okay, this is again a factual weird question. The half of letrozole. Letrozole we all know is an ovulation induction agent. It is also used in breast cancer, and the correct answer is 2 days. The closest answer to 2 days was 45 hours. This is given in most books, but it's like we know not many people do actually read it because it doesn't. It's never come in the past. It doesn't seem to be that important either, but now it is important. Which is incorrect regarding diabetes in pregnancy? Again, direct question picked up from Williams. There's a table in Williams. If you go to diabetes, management of diabetes and labor, you'll find this. Okay, so the correct answer is what are the options? Elective LSCS does not decrease the incidence of brachial plexus injury. In active labor, if the RBS is less than 70, 5% dextrose is started till the RBS is more than 100. In a patient being planned for induction, her night dose is given as planned and the morning dose is also given. And these are the target blood glucose, capillary blood glucose levels. And the correct answer is this is wrong. Why? Because we withhold the morning dose. We don't give the morning dose. We withhold the morning dose, start her normal saline, and then do a early glucose monitoring. So this is what Williams says. There is insufficient evidence to suggest that elective LSS reduces the risk of birth injuries. Usual dose of intermediate insulin is given at bedtime. Withhold the morning dose. Start on NS once active labor begins and glucose levels drop. Then change the infusion to 5% dextrose at this rate until you achieve a glucose level of this. Early glucose levels are checked, and regular short-acting insulin in an IV infusion 1.25 units per hour if the glucose levels go above 100. And these are the goals. We all know this. Fasting should be less than equal to 95. Pre-meal should be less than equal to 100. 1 hour postprandial should be less than equal to 140 milligram per deciliter, and 2 hours should be less than equal to 120 milligram per deciliter. This is also a previous year. I think it's a previous year, but it is an important question. And I think most of you got this right. Factor 11. So what happens in pregnancy to the coagulation system? It is pregnancy, we all know, is a hypercoagulable state. fibrinogen levels are increased, ESR is increased due to increase in globulin and fibrinogen. This has been asked in the past. Platelet count, there may be a slight fall. And what happens to the different clotting factors? We have an increase in 1, 2, 7, 8, 9, 10. Okay, these are increased. These remain unchanged, 2, 5, and 12. Okay, or mildly increased. So 2, usually we'll say it is increased. Factors 11 and 13 are slightly decreased. So remember 11 and 13. Right, 13 is unlucky for some, that's why it's decreased. Another way you can remember is 11 is what came in this INICET. So 11 and 13 are slightly decreased. Clotting time is unaffected. Okay, so this is about coagulation in pregnancy, which is incorrect regarding innervation of the uterus. Again, it was not a very interesting question, more of anatomy, I guess, incorporated, integrated question. So I'm not very sure about this option, okay, if this was the correct answer, but I think this was what is wrong, because the innervation is not at the level of T7, T8, the innervation is at the level of T10 to L1, okay, and that is why there is pain in the uterus so in the first stage of labor, the level is T10 L1. In the second stage of labor, there is perineal stretching and the pain is transmitted through the pudendal nerves, that is S2 to S4. And Frankenhauser plexus is the uterovaginal plexus, which lies lateral to the cervix. So I think the most likely answer would be this, but I'm not very sure. If anyone knows what the exact question was, you can let me know in the comments section. Kassovitz law. Okay, Kassovitz law was used to be asked many years previously, and it's so rare. Congenital syphilis is so rare, but again they like asking rare things, and you almost never see it nowadays. Maybe 5, 6 decades earlier, syphilis used to be at least heard of. Now it is not even heard of, and to see congenital syphilis is such a rare thing where they like asking rare things, and I think most of you knew this. Okay, so what is Kassovitz law? It says that the prognosis of the fetus keeps improving with each pregnancy in a woman who has syphilis. Okay, so if in a woman with untreated syphilis has a series of pregnancies, the likelihood of infection of the fetus in later pregnancies becomes less. This is exactly what the law states. Okay, that means in the first pregnancy she may have an abortion, and the next pregnancy she may have a intrauterine death. Then she may have a baby born with congenital syphilis. Then she may have a normal baby with no features of congenital syphilis. This is what it says. The prognosis keeps improving with each pregnancy. Okay, so that's Kassovitz law. Okay, another difficult one. Okay, so what was this? An immune checkpoint inhibitor approved by the FDA as a single agent drug in advanced endometrial cancer, and the answer is pembrolizumab. And again, see when this came out in March 2022. Okay, so this was again. I found it only on a Google search. To be honest, I didn't find it anywhere else. And this is something as recent as March and April. Also, they're asking stuff, and these are questions which most people won't be able to answer. So don't worry about these. Okay, don't think about these sort of questions because most people won't know them. They're rare, very rare, and they're just put there just to make the difficulty level higher, but don't bother about these. Very few people would have got them right. Okay, this is a pathology question but relevant to gynae, so I put it here. This histopathology image is seen in which tumor? Now what is this? This is a Schiller-Duval body. How do you know? This is a vessel. This is the center. This is a vessel and surrounded by these cells. This is typically seen in a yolk sac tumor. Don't get confused with Call-Exner bodies. Call-Exner bodies look different. Okay, so how to call? I'll tell you how they look like. I will just club this with the second, match the following question. Schiller dual bodies are seen in yolk sacs. Syncytial trophoblasts, we all know, are seen in choriocarcinoma. Large cells with prominent nucleoli and lymphocytic infiltration are seen in dysgerminoma, and cartilage, bone, neuron, we all know. Multiple cell lines are seen in teratoma. So this is how Schiller dual body looks like. Okay. And this is how Call-Exner bodies with coffee bean nuclei look like. These are seen in granulosa cell tumors. Okay, these are the coffee bean cells, nuclei, and these are the Call-Exner bodies. They're punched out lesions. Basically, I agree they look a little similar But these are the classic pictures. Okay, these the this image, this is the exact image that was asked in the exam, and this is how call external will look like. They look like, see the nuclei, they look much bigger, like coffee beans. Okay, and this is basically, this is the vessel, and surrounding these you have these sort of rosettes formed. So this is Schiller Duval body, this is called external cells. This is how this germinoma looks like. Okay, they have basically prominent nuclei, and you have lymphocytic infiltration. Choriocarcinoma has syncytial trophoblasts, and this is a teratoma. You have different cell lines. You can have hair, you can have sebaceous glands, all that. Okay, which is incorrect regarding the biophysical profile. Now, this was a question which still I am not very sure, because I don't have the fourth option, number one. And let's see the options though. BPP consists of, so biophysical profile consists of, yes, yes, tone, breathing, and heart rate reactivity. So this was correct. Okay. Next was BPP correlates with both fetal pH and fetal outcome. And next was BPP less than equal to 4 indicates a pH less than equal to 7.2, and a BPP less than 2 has a 100% sensitivity for acidemia. Now, again for this I had to go to the book, okay, because and I don't have the fourth option, okay, so I don't know what that was, but this seems to be the incorrect option to me. Okay, why? I'll tell you why. So when we talk about biophysical profile, and what Williams says is that a good biophysical profile, a score of 8 or 10, right, has good outcome. Okay, and a score of 2, 0, 2, 4 has a bad outcome. In fact, they say, Williams says, a score of less than 2, the baby is definitely going to be acidotic. Okay, so this also correlates, but it does also say that equivocal scores, okay, that is score of 6, okay, can have either a good or a bad outcome. So Williams clearly put this is verbatim from Williams. Overall, Manning score has a poor sensitivity to predict cord blood pH, and except if it is very low. Okay, and BPP has limited value in the prediction of fetal pH, especially if the scores are equivocal. So I need to know the exact lines that came to be able to answer this better. Okay, and I need you guys to help me with that. Okay, but remember Manning score, that is the score in the biophysical profile. On either extremes, it predicts the fetal outcome. If it's very low, it predicts a bad fetal outcome. If it's very high, it predicts a good fetal outcome, and correlates with the pH also. But the equivocal scores do not correlate with the pH or the fetal outcome at all. Okay, so you can have a baby with a 6 score who has a very poor who is in acidosis, or you can have a baby with a score of 6 who comes out completely fine. So this question I need more clarification. Okay. Next question. Modified BPP is NST plus fetal tone. NST, and this is easy. We all know modified biophysical profile is the NST plus the amniotic fluid index. I won't explain this more. Okay, okay, this was the one of the bad questions. Okay, 25-year-old woman with lepromatous leprosy on multi-drug therapy in pregnancy presents with type 2 lepra reaction. Okay, that is erythema nodosum lepromatosis, I think. Is new for me. I don't think I've read Leprosy after my MBBS days ever. How will you manage her? Okay, so the correct answer in this is don't stop MDT. Okay, so continue multi-drug therapy, which is completely safe in pregnancy, and just add corticosteroids. We all know thalidomide is contraindicated in pregnancy because of the instance of phocomelia, and corticosteroids can be safely given in pregnancy, but don't stop MDT. This was there to confuse you. Okay. So leprosy in pregnancy, what I learned today and what I think I should share my knowledge with you is leprosy can be exacerbated during pregnancy, and without treatment, it can permanently damage the skin, nerves, limbs, and eyes. Therefore, it is important to treat leprosy. How do we treat it with MDT, and what do we give? What are the drugs safe in pregnancy? Rifampicin is safe, Dapsone is safe, clofazimine is safe. If there's a type 1 or type 2 lepra reaction, add corticosteroids. Thalidomide is contraindicated. So that's what I learned today in the little bit time I got to do a bit of studying. So if I get to know more points, I will add on in the comment section. Okay, which is incorrect regarding lupus nephritis in pregnancy? Ecosprin, corticosteroids, mycophenolate. So this you could easily answer by uh, because we do know that, at least we all know, methotrexate is definitely contraindicated in pregnancy. It's not safe. So this is the correct answer. In fact, mycophenolate mofetil is contraindicated, methotrexate is contraindicated, and cyclophosphamide. All three are teratogenic and are not cured in pregnancy. Yes, we continue immunosuppression in a patient who has lupus nephritis even if she's pregnant, and if she has an acute lupus flare, we give aggressive we do aggressive management with high dose corticosteroids. It can be given in pregnancy. And also, yes, so if there is no evidence of renal dysfunction, then only the patient, a patient who has SLE should plan pregnancy. Once there is quiescence of renal or there's no renal disease, there's quiescence for at least 6 months. Okay. So a little bit about lupus nephritis and pregnancy. So pregnancy outcome is best if lupus activity has been quiescent for 6 months. There is no lupus nephritis as evidenced by absence of proteinuria and good renal function. APLA is not there. So APLA, many times APLA coexists with SLE. APLA is not there and superimposed preeclampsia does not develop. Then this woman will have a good prognosis. Active nephritis is associated with adverse pregnancy outcome because of preeclampsia and hypertension. Okay. And it is recommended to continue immunosuppression in pregnancy. New onset nephritis, treat aggressively with high dose corticosteroids and IV immunoglobulin can be given. So this is about lupus nephritis in pregnancy. Again, direct question from Williams. Word to word, these statements have been picked out from Williams. What are the drugs contraindicated? Mycophenolate mofetil, cyclophosphamide, and methotrexate are completely contraindicated in pregnancy. Next question, which is the correct statement regarding neonatal antiretroviral therapy? And I think most of you would have got this. Okay, so irrespective of the neonatal status, we continue nevirapine till 6 weeks post delivery. This is very important to understand. Even if the baby is HIV negative at birth, okay, which is confirmed only at 18 months of age, irrespective of HIV negative positive, still give post-exposure prophylaxis with nevirapine till 6 weeks of birth. And this is, I just put the NACO guidelines. This is given directly from NACO. ART in HIV in pregnancy, very, very important topic. High yield topic, very, very important. And remember, we follow the NACO guidelines and this is from there. Okay, consider these tests. This is actually a forensic question, but I found it relevant to gynae, so I put it here. Which of these tests, this is a multiple answer question, which of these tests would you use to determine vaginal cells on a vaginal smear in a patient with suspected vaginal assault? Okay, so remember the answer here is only Lupul's iodine test. Why? Remember, Barberio's test is, so these two tests, Barberio's and Florence, are for detection of semen. Okay, so this detects spermine, this detects choline, which is seen in the seminal fluid. Precipitin is detection of blood. And Lugol's iodine detects vaginal epithelial cells. It stains them a deep brown color. Okay, so this is important. Lugol's iodine is for vaginal cells. Which is true regarding anti-Mullerian hormone. Again, a high yield topic and important. This is AMH is now very, very being commonly asked. Okay, in different forms, so you should know about it. It decreases sensitivity of the preantral follicles to FSH. It is a lipoprotein secreted by granulosa cells. It correlates with pregnancy outcomes. It is best tested in the fasting state in the second day of the menstrual cycle. Okay, this is wrong. Okay, it is best. It can be done anytime. It doesn't have to be fasting. It doesn't have to be on day 2. Those are only FSH and LH. Okay, it correlates. It doesn't correlate with pregnancy outcome. This is also wrong. It correlates with the ovarian reserve. It has not been found to have a good correlation with the outcome in IVF pregnancies, but it has a very good correlation with the ovarian reserve of the woman. It is not a lipoprotein, it is a glycoprotein. Okay, it is secreted by the granulosa cells of the preantral follicles, but it is not a lipoprotein, it is a glycoprotein. And yes, it decreases the sensitivity of the preantral follicles to FSH. So this is the correct answer. Read about AMH, it's very important. What is true about genetic screening tests? And a lot of questions from genetics did come. This one was relevant to gynae because we use genetic screening tests in antenatal screening. Okay, Down syndrome screening, we use these tests. And most are invasive? No. Okay, they are more accurate? No. They help define the risk of a genetic defect? Yes. And they're not done by gene mapping. So this is genetic screening tests. If we talk about Down syndrome screening tests, we use biochemical markers, we use ultrasound markers, and that's how we screen for genetic disorders. So if you have any different opinion about this, let me know, because I took this in context of antepartum genetic screening, right? So if you have any doubt, any other views about this, please let me know in the comment section. Okay, fingerprints appear at fetal life. When do fingerprints appear? They appear at 12 to 16 weeks. So this is the correct answer, and are established by 24 weeks. So the answer is 12 to 16 weeks. Again, forensic medicine with relevance to obs and gynae. So I did put it here. Okay, next question. A 28-year-old woman has an uneventful term vaginal delivery. On the first day, she complains of visual disturbances and a severe headache. 2 hours later, she is found unresponsive with profound hypotension. She is intubated and put on mechanical ventilation. Her BP is this. Pulse is 148, saturation is 95. Remaining examination is unremarkable. On investigations, her RBS is 49. WBC count is normal, which is the drug of choice to reverse this condition. Okay, so what is the diagnosis? What do you think the diagnosis is here? Okay, so this is a little, again, a little um, difficult. What would best fit into this sort of picture? There are two things I thought of: cortical venous thrombosis and pituitary apoplexy. Okay, so what didn't go in favor of pituitary apoplexy was that there's no history of PPH. It says an uneventful term delivery, and pituitary apoplexy in the context of pregnancy or post delivery happens when there's a lot of hemorrhage, and that leads to necrosis of the pituitary gland, and then it would respond. It would respond to. Present with this picture, and the answer would be to give corticosteroids. Cortical venous thrombosis is the second differential I had, because again headache and visual disturbances are common with CVT, but again nothing else fits in CVT. Okay, so the TLC count is normal, and here you would give coagulants as the drug of choice, and that was not then the option. So all in all, this fits more towards pituitary apoplexy than cortical venous thrombosis. Okay, and so the answer should be hydrocortisone. Okay, so a bit about uh, pituitary apoplexy or Sheehan syndrome is that the treatment of choice is IV fluids and glucocorticoids. It presents as reduced acuity, headache, also altered state of consciousness. And when pregnancy is a precipitating factor, it usually is associated with postpartum hemorrhage. But that was not here in the case. But despite that, everything else was fitting into the diagnosis of pituitary apoplexy. Next question. A 23-year-old recently married woman is referred to the outpatient department for an episode of mania. She had a similar episode a year earlier. The couple expresses a desire to conceive. Which drug is completely contraindicated in view of teratogenicity? Now, if we see this list of drugs, okay, so we know amongst all of these, lithium is definitely teratogenic, and oxcarbazepine is also, and sodium valproate is also teratogenic. Now, remember, amongst these, this has the highest teratogenicity risk, up to 10%. Okay, lithium is associated with Epstein's anomaly, but again, rarely. Oxcarbazepine also is an anti-epileptic, but it has a rare incidence of, or not so high, 2 to 4-fold higher risk. This is a 10% risk, and sodium valproate is definitely the most teratogenic drug in this group of drugs given, and that's why this should be the correct answer. Okay. And the last question, I think this is, which is incorrect regarding postpartum hemorrhage. And again, believe me, these sentences word to word have been picked up from Williams. Okay. Blood loss of more than 500, we know this is the correct answer. Prolonged labor, multiple pregnancy, chorioamnitis are risk factors. Initial management is colloids. No. Initial management is crystalloids. Okay, remember this, and I think most of you would know this. You have to first start crystalloids. Okay, and this is the IV fluid of choice, not colloids. And if the hematocrit, this sentence was directly picked up from Williams. If the hematocrit post delivery is less than the hematocrit admission, the volume of blood loss can be calculated by adding 500 ml for each 3 volume percent drop in hematocrit, and this is correct. This is how you calculate the amount of blood loss in delivery. So this was another question, and this was the correct answer. So I think 34 questions we have here. If you have any more, please add on to them. Okay, and please subscribe to my channel. We will be coming out with a NEET PG solutions also. Okay, but don't worry. I know this was not a very expected paper. This was not a nice paper, honestly. That was my opinion. Compared to the previous INICETs, this was very odd. Odd is the right word. Okay. But don't worry if you think this is going to be there in NEET PG. No, NEET PG is a much more straightforward paper. Concentrate on images, they will be there. Concentrate on basics, concentrate on previous year questions. Don't make silly mistakes. Don't get what you know wrong, because they tend to confuse you in the exam. Two choices will look similar. Go with your gut instinct. Okay, so that's my advice. Go with your gut instinct. Don't make silly mistakes. And I wish you all the best for the NEET PG exam, and of course for this result also. If it's tough for one, if it's tough, it is tough for everyone, right? Not a single person I met has said the paper was even moderate or easy. Everyone, and I've spoken to a lot of students, everyone has said the paper was definitely tough. So one day you will thank yourself for never giving up. Never, ever, ever give up. Sincere advice to everybody: never, ever, 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 ever give up. You can do wonders, and I wish you all the very, very best.